All right, welcome everyone. This is number 18 webinar series sponsored by Ethio-American Doctors Group. This will be, I think, the last of this series, and the next new series will start next week. And I'll give you more information at the end of this webinar. So the purpose of this webinar is, like I said earlier, is mostly for discussions and answering your questions and comments. I do have some interesting cases and a little bit of updates on COVID, but interesting cases on non-COVID mechanical ventilations, which I'm going to share with you guys. And when the panel join us, and I will open the floor for them as well as for you guys. So just forward your questions in the meantime. I will try to make it somewhat informal. Okay, let me share screen. Why can't I share screen?
If you scroll towards the bottom, you would see a green share screen button.
Yeah. It won't allow me though. Someone. Okay, let me see. Check computer sound.
You want to send it to me and quickly?
Yeah, I can do that. I just did.
Okay, can you see my screen now?
Let me see if that's the one I wanted to share, brother. I'll show you. Oh, that's okay. I see my screen. You're doing yours. That is the PDF. Hold on. I gotta send you another one.
Elias, are you trying to share your screen?
No, I wasn't able to share my screen, so I'm gonna send you the actual presentation. The one I sent you is, I think, wrong one.
Okay.
So it will take just 1 minute. In the meantime, I'll actually start the update. Let me just send this email real quick. Okay, I just did. So one of the cases that I wanted to touch on it is the ventilatory strategy in acute severe asthma, as you can see on the screen. And I'll share my presentation with the case when Malaku gets the email. So I want to touch on that because I think that's one of the cases you probably will encounter in your ICUs, and probably one of the most challenging ventilator management due to the nature of the disease. Because in severe asthma, I think that the presentation is, it usually it has two ways of presenting. One is this chronic cough, slow progression of shortness of breath in 2 or 3 days. Then eventually they will be tired and present to you, and you decide to intubate them for worsening hypoxia or hypercapnia and fatigue. And the other one is they suddenly collapse and
Elias, the presentation is on now.
my presentation is not. I don't see it.
It's on now. Can you see it?
I only see the case report there.
No. The mechanical ventilation case presentation. You don't see it.
I don't. Do you guys? I don't know the others do. Can you do it again? So what I was saying. So there's they have two who are presenting. Okay. See if you can share it now. Okay, thank you. I think I did, then it went away. Okay, I can see it. Can you go to the next slide? Oh, okay. Can I run it or you have to do it?
I have to run it.
Okay, so this is just a case presentation. 48-year-old, non-bronchial asthma, presented with acute exacerbation and hypoxia. I don't know what kind of bronchodilator she used. Like in Ethiopia here, we use albuterol, which is a beta agonist. And it was given steroid and empiric antimicrobials, as well as oxygen. But patient continued to deteriorate. So he was immediately intubated with a bigger ET tube after getting ketamine and vecronium, which is the non-depolarizing neuromuscular blockers that we use for intubation. Next page, please. So what's your criteria for intubation in severe asthma? So like I said, so these are the most common ones we use. Hemodynamic instability. I don't know that you guys still use pulsus paradoxus. Just to remind you that means the systolic blood pressure difference during inspiration. And it's normally it's about 10 or less. And in severe asthmatics, like asthmatic status asthmaticus, could be significantly high. And that will indicate pending hemodynamic collapse. And of course, refractory hypoxemia despite your efforts. And the other one, what they call silent chest, that's probably one of the most dangerous ones, where there's no movement at all. And of course, if you have access to blood gas, hypercapnia or respiratory acidosis. Next, please. So in asthma, I think so. The purpose of this discussion is just to point out what you need to watch on. What makes a difference is, you know, in asthma, you got to use the largest ET tube because the whole mechanism of the disease is a narrowing of the airway, right? So you try to avoid any resistance, and usually after you intubate this, I think the most dangerous is building intrathoracic pressure. So what you try to maximize is ventilation. So the last two series on mechanical ventilations, if you remember, presented by Dr. Zayoun. So in any kind of obstructive length, especially in severe asthma, you maximize the exhalation time. One of the way you do it, you lower the respiratory rate. So that will prevent you this hyperdynamic inflation or lung hyperventilation, which has a different name. So they call it air trapping, auto-PEEP. So you're dealing with pressure in severe asthma. So the whole purpose is to avoid pressure, maximize ventilation, and do not aim to have the perfect blood gas or the perfect PaCO2, because you have to compromise what we call it permissive hypercapnia. You let the CO2 be higher as long as you can control the pH, and as long as you can keep them alive and ventilating them. Because I think majority of complications are barotrauma to the lung, and they're complicating in the pneumothorax, and that will result in high mortality. And some of the other things you can do is you can humidify the air to prevent any thickening of secretion, because that actually makes the whole disease process worse. And that will stimulate more bronchospasm by itself. Next, please. And in the meantime, this is just to remind you, auto-PEEP, and Dr. Zayoun did go through this in more detail on the last two presentations. And as you can see, this is just a waveform that you can see on your ventilators. And as you can see, the flow doesn't go back to zero. You remember from the last two series of presentations, and the first one by John as well. And this was supposed to go to here before you start inhalation again. So here, so this will continue to build more positive pressure, and that's what they call it, intrinsic PEEP or auto PEEP or air trapping. And that will lead to increased intrathoracic pressure in general. I think this is cut on this slide, but you can see on your ventilators, you should be able to see the peak airway right there at the corner measurement, and you want to keep that as low as possible. So and at the same time, the plateau pressure, as you can know, you should be able to measure it on the machine, and you should keep it less than 30. And make sure that there is no auto PEEP. I think the easiest way to know is by just looking at the flow waveform. And the other way is that actually on the machine, you can push a couple buttons and it will spit out numbers for you guys about what's the intrinsic PEEP is. And that will create a lot of problems if you remember the synchrony, of course, increased intrathoracic pressure. So in extreme cases, that can lead to cardiac arrest and just this discomfort in general. So unfortunately, if so, you have to control the patient and patient's ventilation and the relationship between the vent and the patient. So you will use necessary pain medication, sedatives, or paralytics once in a while. That will, of course, lead to more complication down the road. Your weaning success will be very low. And so that I don't want to go through how you lower this, because Dr. Darwin had a beautiful discussion about flow and IE ratios. Go ahead, the next one. So this is just a brief summary, what mode you should use in that. And again, there is no, this mode is from facility to institution, so it differs. So AC, which is assisted control, volume control, is the most common mode you use. But if you're comfortable in pressure control, you go ahead, you can use that. Should be able to manage them just fine with it. But for example, our institution's to-go mode is ACVC. So, and we just have to, I think if you guys are in a position where you're running your ICUs and ventilators, you should have, an institution-wise, you should have a mode that everybody is comfortable with. And the ACVC seems to have a lot of data in almost a lot of facilities, almost all facilities, that's the default mode. And the same is true for us. Remember, respiratory rate less than 10. And you try to maximize expiratory time. And of course, minimize auto PEEP. So how do you do that? You lower tidal volume. And you increase the flow, right? And increase the IE ratio, the inspiration expiration ratio. You give them more time to expire rather than inspire. And especially if you use a higher flow, you can do that because the first 1 second or 2, they get all the flow they need, and the next 5 or 4 seconds they spend on expiration. And now, and apply to pressure, try to lower it. And I will ventilator-induced lung injury minimize. Next, please.
Dr. Zarihun has joined as well, by the way.
Okay, so Dr. Zarihun, as soon as I'm done with this presentation, I will open the floor for you guys, and if you have any update on COVID and related. So just continuing on asthma presentation. So try to, your saturation of O2 target should be lower. And because oxygenation is usually not an issue with them, so you don't need to go crazy on your PEEP. So you focus on ventilation, like the square waveform as discussed last 2 presentations. The square waveform seems to be the most common, and I will give you quick flow and minimize the time for inspiration. And of course, the whole purpose is minimize the auto PEEP applied to pressure. If you have access to blood gas, so we tend to keep them above 7.2. And again, so permissive hypercapnia to minimize lung injury. So we're not trying to have a perfect CO2 and pH. That's not the goal. Once in a while, if you struggle with the pH, you can use bicarb, which is not usually advised, but that will give you time to vent the CO2 out. So next, please. Of course, don't forget your pharmacological agents that you can use, including your bronchodilators. And in severe asthma, magnesium sulfate has a role as adjunctive therapy. And as a sedatives, I think ketamine seems to be the most preferred one because it has got not only analgesic and conscious effect, it actually helps in causing bronchial smooth muscle relaxation. Of course, the steroids are mainstay of treatment as well. So before I go to the second one, I will invite Dr. Zarun. Dr. Zarun, are you with us? Dr. Zarun.
Yes, I am, Elias.
Okay, Zari, thanks for joining us. So I see Dr. Tigist is here with us too. So again, the purpose of this discussion is a panel discussion and address the participants' question. But to fill in the time, I had some cases which I thought was interesting. So having said that, I will open the floor for you, Dr. Dayan, if you can give us. So I think if you can give us any updates since we start this about 5 weeks ago, I think. And I know in the era of COVID, 5 weeks is like 5 years. So a lot has been changed. So, would you mind giving us some of the updates on COVID World, mainly on you touched on the ventilator part, pretty much the new understanding. But can you say anything about treatment parts, where we are now on the treatment part, Dr. Tariwan?
Yeah, thank you, Elias. So, I think as you said, right, every day is really a ton of information. It's difficult to catch up, in this COVID information world. So, again, I think the few big things, which came up are one, the anticoagulation part is really is getting larger attention. And many universities and hospitals have changed their policies through time, and everyone has different. But I was able to look at a few of them. There is a focus to do a little more prophylaxis than the usual ones. Typically, like if the D-dimer is a little bit say more than 3, the tendency is to use at least 0.5 per kg of Lovenox, which could be daily or BID, and especially if it is greater than 10, there is a tendency to start full anticoagulation in some facilities. The other thing, if the patient went on dialysis or CRRT, that's another area where they definitely use anticoagulation, full anticoagulation, because it is shown that the filter is changed so many times in COVID patients, so they are hypercoagulable, and they have to be on this. And I think you all have read the articles on stroke and related diseases. So I think it's not surprising to see MI or PE or stroke or any of those with this. So I think we should keep very suspicious eyes, or we should have a high index of suspicion. Such patients have potentially COVID, especially if it is the presentation is different than what we know the usual. So I think the antiviral wise, I think I would say Elias would say better than me, but I know in US the FDA give approval for a remdesivir like an emergency approval, for use. And still there are facilities, some who use hydroxychloroquine. Some of I know some hospitals also stop using it. So it's a personal choice. There is debate, but a lot of antivirals options are there, especially antiretroviral, and some of them seem to work as well. What else? the anti-inflammatory business still is out there, and this is for selected patients. The other thing I think, which I don't know if it's possible in the Ethiopian setting, but many patients we treated with plasma, and it's a hit and miss. Some of them do very well, some of them do, not get any benefit at all. So, but something you can try if you get a patient who can give a consent. So that's another potential treatment. If it is possible to get plasma of these patients in the Ethiopian setting. So I think those are the things I could remember in my mind. I don't know, Elias, anything you want to add or take us?
So yeah, thank you, Zairun. So a couple of interesting things. The tip for me is the steroid business. So you guys, if you guys remember, when we first started seeing these patients, the CDC and the WHO recommendation is not to use steroids for mainly viral replication and infection control issues, and there was no data that it's shown any improvement. But as we've seen from our experience and from people's experience, and steroids actually seems to have a more role in controlling the inflammation than first thought. So I don't, you probably have seen it in Society of Critical Care. A group panel came out with this recommendation, and they were strongly against WHO's recommendation not to use steroids because, I think our understanding is what kills these people is this dysregulated inflammation. It's not the viral replication. They can continue to shed viruses that will have implication in infection control, but it doesn't have any implication in patient's mortality. Most of them actually, they die of this dysregulated inflammation that leads to multi-organ failure, including ARDS, renal failure, strokes. And we have in our institutions actually are using more and more steroids and earlier. For example, our protocol calls for 40 milligram twice a day, from moderate to severe, especially if you see if they have a significant inflammation based on your CRPs, I'm sorry, and ferritin, and also the dimer. So, and steroids are to go for a couple of reasons. Yeah, one is, as you mentioned, the interleukin-6 receptor blockers are hard to come by, especially in Ethiopian situation. The one we use is tocilizumab, and we have seen some positive outcomes, but as you can imagine, I mean, it's hit and miss, and the problem with that is unless you have in-house measurement of the IL-6 level, which we don't, and we don't wait for that level to come. So we base our decisions based on the ferritin and the CRPs. If that shows us evidence of cytokine release syndrome, we go ahead and start the patient on the IL-6 receptor blocker, which is tocilizumab, and also follow that with the steroids. And sometimes actually we start steroids early and long is that what we do. Start early, we start and we continue that throughout their course. And the remdesivir era, as you just suggested, it just got an emergency authorization by FDA, and unfortunately, the government distribute that, and unless your facility is one of the selected ones, you don't have any access, and we don't have any access because our facility is not select. And the data is, again, in this COVID era, there is a lack of data, but the data, couple things on the data that I can comment on, if I can wear my infectious disease hat here. So if you look at the data, there was no difference in viral replication under the two groups. And so the whole purpose of this medicine is it works by RNA synthesis, right? So it's antiviral. So you would expect there would be less viral load in the treatment group than the control group, but that wasn't the case. So, and that makes me suspect whether this actually works or not. But anyway, again, access is limited, and and I have no experience, zero experience on it. And the anticoagulation, you just pointed out that it's a pendulum. So, we started with low dose, then went up to higher dose. Now we are at the moderate dose of anticoagulation because, number one, we have seen some bad outcomes, especially with bleeding wise. You gotta keep an eye on RP, retroperitoneal bleeds, intracranial bleeds, when you use them. But as you suggested, I mean, if D dimer is high and the risk of DVT and PE seems to be extremely high, so we tend to use the moderate to high dose of anticoagulation. So that's, I think, some of the updates I have. And hydroxychloroquine is out of favor now. Number one, the data did not show any significant benefit, although FDA did give it emergency authorization. So, and that's one of the two that has gotten emergency authorization is hydroxychloroquine and remdesivir. But really, I mean, and maybe it might have some role in earlier presentation, but in ICU, in our line of business, it really, by the time we see these people in the unit, as you know, it's kind of too late for hydroxychloroquine to work. Do you agree with that?
If I say, I mean, the same thing, I think the antivirals are better in the earlier phase, but when they arrive in the hospital, when they are to that level, usually it's a late level, for antiviral. Anyways, if you have it, you have to try it, but typically the earlier, the better, even from the influenza, drugs, we know this, right?
Okay. So I have a question here from the audience. I think it's mainly on PEEP. How much PEEP to be used, I think, by Girma at the beginning. I think you're referring to the earlier presentation on asthma. And like I said, I think PEEP is usually not an issue. Now, PEEP-5 is usually to go a lot of places. So now in our facility, I think PEEP-8 is the default PEEP. They have a different reason for it. But usually we have to have certain PEEP to keep the alveoli open at the end of expiration. So PEEP-5 is the way to do it. Unless you have specific reason to increase the PEEP, or either oxygenation or one of the management of auto PEEP is sometimes you try to match them where they are, but there's no clear reason to use IPEEP in earlier management of asthma. Like I said, asthma is a ventilation issue, not oxygenation issue. The oxygenation is more of ARDS that Dr. Zarun did give a lecture on the last two. So, Doctor, if you have any comment update, otherwise the case 2, I'll present the next case and we can go to addressing questions, or and I'd like to hear your opinion on COPD management. Can we go back one more to the case, Malak? All right, so this is a 55-year-old with a history of COPD present to the ED, with 2-day history of worsening shortness of breath, had a recent viral infection. We see this, by the way, a lot. So, and ER is autosat was 88%, and he's working hard to breathe and only speaking in short sentences. On exam, he has diffuse wheezes and prolonged expiratory phase, and his X-ray reveals consistent with COPD, but no new focal infiltrate. Blood gas looks like this, with a little hypercapnia and acidosis and acceptable oxygenation with PaO2 of 62. Next slide. So on this slide, I just want to touch a couple points, the management is similar to asthma, although the severe asthma is extreme presentation of bronchospasms, and usually COPDers don't have that kind of bronchospasm, but they can have that kind of bronchospasm, and they can present with a severe acidosis, mainly respiratory acidosis, hypercapnia. There's no specific threshold to intubate them. So you consider the whole clinical situation, how sick they look, how are they working, what their mental status. And of course, if you have access to blood gas, their hypercapnia and hypoxemia is that dangerous enough to put their life at risk. So you have to take all that into consideration before you decide. The other thing is, can you use other mode of ventilation, what we call non-invasive ventilation, and deliver the same amount of support prior to intubation is very important. We do use BiPAP a lot. CPAP doesn't have a lot of role in actual COPD exacerbation, because that's mostly oxygenation issues. So, but the bi-level positive airway pressure, that avoids a lot of intubation, but if you use it early on. But if they are worsening mental status, worsening hypoxemia or hypercapnia despite use of BiPAP, then intubation is recommended. Of course, if they are hemodynamically unstable with multi-organ dysfunction, that's another reason to use it. Any comment on COPD? Anyone?
I think Elias, you very well covered it. So I think really not much. So, and I think on the extubation side also, I think something we can think of extubation to BiPAP is, you don't need to, they don't need to stay like for a long time on an invasive ventilator. They can be, extubated to BiPAP. So that's one thing I would say.
Yeah, I think that's true, and that works for asthma too. So, especially in severe bronchospasm like COPD and asthma, they tend to respond to your treatment very quickly, and normally we don't usually keep them intubated for more than 24, 48 hours, unless they have other reasons that got them there. Like, for example, if they have superinfection with pneumonia, or their hemodynamics are unstable for one or another reason, or if they have associated cardiomyopathy with severe CHF. So those comorbidities are actually what keep them on mechanical ventilation longer than the actual COPD or asthma, especially in asthma. If their presentation is acute severe bronchospasm, their response is also very quick. It could be with less than 24 hours, you might even be able to extubate them. And extubation to bypass, especially in COPDers, increase the success, as Dr. Darian pointed out. Next slide. So this is kids of, I think, pneumonia. So 45-year-old, 6 foot tall, present to the ER with a 2-day history of fever and cough productive of brown sputum. When he presented, he was hemodynamically stable. The blood pressure 130/87. X-ray showed right middle lobe infiltrate. and blood cast presentation of 7.32, PCO 232, PO 278, with bicap of 18. So he was started on antibiotics, admitted to the floor. 4 hours later, the nurse calls because she's concerned that he's doing worse. On your arrival in the room, his blood pressure is 85 over 60, pulse is 120, oxygen saturation, which was 97% on 2 liter, now it's 78% on non-rebreather mask. He's laboring, use of accessory muscles, less responsive than he was on admission. He's very diaphoretic, cannot talk full sentence. On exam, he has crackles throughout both lungs. So it's a sex ratio increasing bilateral diffuse lung opacity. ABG done while he's on non-rebreather. This is what it is: severe acidosis, CO2 45, PO2 58, and bicarb is 14. Next. So what should you do now? Is there a role of bi-level positive airway pressure or CPAP? So as you can see, patient is struggling to breathe, right? Mental status is declining. He's hemodynamically unstable. If you look at his blood pressure, his presentation was 130 systolic, now it's 80. His oxygenation and ventilation, especially his oxygenation, has gotten much worse. His CO2 was 43, and his pH is pre-acidotic. So in this case, when they are hemodynamically unstable, earlier I mentioned the role of bi-level positive airway pressure. Earlier it might have a role, but by the time they are this sick with hemodynamic instability, mental status declining, and with this level of hypoxia, so usually the failure rate of bi-level or CPAP is tremendously high, actually increased morbidity and mortality. So the best option for this patient is make sure you have adequate blood pressure for your sedation and intubation. Yeah, and that's also a very important point too. So you have to up his blood pressure somewhat using either adequate resuscitation or vasopressors so that you can sedate them well and intubate them. Otherwise, actually intubation might lead to even worsening, including death. So you have to make sure it's stable. But using CPAP and BiPAP is just delayed and probably impact the outcome of the patient. So if they have easily reversible like cardiogenic pulmonary edema, they might have a role. But this guy's presentation, remember, he's got evidence of pneumonia already. So you can feel free to comment on this one, Dr. Zorio.
I think it's well stated, Elias. So
next, please. So which mode is better for your patient? And as I touched on during the asthma discussion, usually the go-to mode is ACVC. But if you are comfortable in, go back one. If you're comfortable in PC, nothing wrong with it. And I know we touched on SIMV being popular back in Ethiopia. And I'm sure it will have a role. So I don't want to go in detail on this one because it's been discussed in very well in the last two. Next, please. All right. So and this also was discussed how you choose a TIDAL volume. Some of here you can use this formula if you want calculation to come up with what TIDAL volume. Usually, the first TIDAL volumes we try to stick to the ARDS protocol, even if they don't have ARDS. and 6 to 8 is the maximum we go for ideal body weight. Just a reminder here, we use ideal body weight, not actual body weight. And ideal body weight is a factor of your height mainly, because remember, your lung, if you get fat, your lung doesn't get fat, right? So you have the same amount of lung, no matter how much you weigh. So it's a factor of height. So, and that's one of the formulas you can use. And there are a lot of tables on the internet you can use to calculate ideal body weight. So, you know, as this example show you, if you have a 150 kilo person, we don't have that big in Ethiopia lab, but we do here. Trust me. So you can give them a 10 ml per kg. That will essentially blow out his lung. So those are just some of the reminders. Anything you want to add here?
Yeah. So typically, if you see, if I put someone on a ventilator, if it is like a man, typically I tend to choose around tidal volume of around 400. That's kind of the average, for a man, and for a woman, typically 350 cc is what I put. So, but I think this is just average number, but you really need to calculate, because later on the patients are going to want to breathe more. So, and in order to satisfy them, to avoid dysynchrony, you may need to calculate their ideal body weight and their tidal volume based on that, and give them appropriate volume. And again, the range is anywhere. You could go as low as 4 cc per kg to 8 cc per kg. So and you can use anywhere there, to as long as the plateau pressure is less than 30. So I think when we use also the plateau pressure, I think one consideration we should always probably keep in our mind is the effect of the chest wall. So if someone is like very obese, their belly weight is gonna put a lot of pressure on the lung, and so that would require a lot of pressure to open the lungs, because normally our chest wall is compliant. The tendency is to open up, to actually goes away, so that because there is a negative pressure in the pleural cavity which tends to pull out. So that is the tendency, and that's why we ignore it. We don't really measure it. But in some patients, this could be positive, like obese patients, someone with abdominal compartment, someone with pleural effusion, or some kind of deformity in the chest, or those kinds of things which would make the chest wall pressure a positive one. So if that is positive, that means your plateau, if it is 30 and the chest wall pressure has 10, then that means pretty much your plateau is 20. So you have more room to increase the tidal volume. But there is no good way to measure this, chest wall. It's like, you have to keep in mind that the chest wall effect in your mind, and maybe you may accept a little higher plateau pressure if you see anything which can increase the chest wall pressure.
Yeah, I think that's a great point, especially in our situation. This belly fat. So you're using using a little higher PEEP to start with might help as well, and we do use that's here right. As well. So PEEP, like instead of people 5, maybe 8 to 10, but that might push away some of the belly fat and structure away from the lung, and open up more space, and of course the issues Dr. Darun just mentioned. So now for the sake of time, and I'd like to go to the next slide, and so we'll go to the announcement. So respiratory rates, how do you choose a respiratory rate? And I think two things that I wanted to point out here, and I'll let Dr. Zarun add on, as mentioned before, so you try to match the patient's minute ventilation, please, because I think most common errors that we make is patient is breathing like 30 times before we intubate them and sedate them, and we leave them at rate of 12. And before you know it, especially patient was been because if they have a significant metabolic demand for sepsis or pneumonia, they're trying to match that, and essentially you take away that from them, and so you have to keep that in mind, especially the first few minutes till you have your first gas, to see where exactly they are. So trying to match them if you know what their minute ventilation is, at least rate-wise, because your tidal volumes, as we discussed, usually we try to limit it to a certain tidal volume, right? So you work on your rate mainly, and it's easy to come up with a rate if you know what minute ventilation you're aiming. All you have to do is just divide it to their tidal volume per ideal body weight and come up with a rate. But I want to keep that in mind, especially immediately following intubations, because of the above reasons. Because if once the paralytics or the sedations wear off, patient will do what they need to do, unless you heavily sedate them. Respiratory rate wise, whatever set you put them, they will breathe over. But you still limit their tidal volume for right reason, because the pressure, you're trying to limit that pressure to avoid any lung injury. But the rate they can compensate, but the first few minutes it's crucial in calculating the appropriate rate. Dr. Zarun?
Yeah, I think I agree on this. This is very important because honestly, we have seen people dying just because of the not putting appropriately breathing. I have seen like patients with DK, and because some people saw a pH of 6.8 or 6.9, and they put them on a ventilator thinking that will be more effective than the patient's breathing. Really, I mean, the ventilator is not effective as what a human can do. So if the patient breathes well and seems to be tolerating, don't rush. If you do it, you really have to be careful if it is physiologically demanded breathing, like in DK case it's a severe acidosis, they are trying to compensate that. So if you put them on a ventilator and if you underventilate them, and this pH will worsen, get into cardiac arrest, and we have seen this in ED settings and so on. So you have to always look at if their breathing is fast for anxiety or pain or anything reason, that is not the case, but you won't know. So I think typically you need to match them. And after the paralytics wears off also, I think the reason you put them on a ventilator is to rest them. So I think just letting them ride, for example, if they are breathing 30 times and your set rate on the ventilator is 12 or 14, and they are that initiation, that 16 difference, initiating every time, every minute, 16 times, that's a lot of work. So I think you need to try to match their work. You don't need necessarily to match to their specific number, but I think if they are 30, I'll try to match them up to like 26, 28, because I want to take that work of breathing, from them, and I want them to rest. If you see, for example, in COPD, what you're doing is when you put them on a ventilator is, their muscle is exhausted and you're just trying to rest them and, give them a couple of days on a ventilator so that their muscle would rest and recover, and then they are able to do the job by their own. So, you try to match, those things for them. So those are, I think, the two things, I add. And
Okay, and so at one of the questions, as you can see, so how do you come up with the appropriate respiratory rate? So Dr. Zaroon just mentioned, the way you do it is you look at the patient and what their acid-base balance, either by blood gas or by estimation. If you know like it's decay or it's sepsis, the underlying etiology, and if they think they are acidotic, your purpose is, so what they're trying to do is to compensate by blowing out CO2, right? So one of the things, so you have to keep that in mind, and so try to have an idea what minute ventilation they require. If you say 10 liters, then just tidal, if your tidal volumes, for example, 500 ml, all you do is divide that 10 over 0.5, that will give you at least 20 respiratory rates. So you have to have an idea of the underlying pathophysiology and what's the driving their respiratory rate, whether it's sepsis or decay, and or it's just pure hypoventilation. So that's how you come up. But I don't, and you estimate their minute ventilation. I don't think there's any that I know of any way of knowing exactly what minute ventilation you need for what the particular disease. But you, so you know your patient, you estimate their minute ventilation, and then the next blood gas will guide you so how to go. Because if you, essentially what we do is we estimate their minute ventilation and we come up with appropriate, what we think is appropriate respiratory rate. In 30-45 minutes, we check their gas, see where they are. So the most mistake a lot of clinicians do is to have this default respiratory rate to go by for everyone. So and that will lead to significant error and of course worsening of the patient condition.
So just, I think, to add on this, to answer, I think, on some of my slides, I included, what I heard in Ethiopian setting, what, the physicians are using is the Untitled CO2. So I think ABG is not available. So, I wanted to comment on this, so, if I share my slide, I don't know if I could do that. Gurma, Melaku, sorry.
Yes, you should be able to.
Okay, so
I'll make you
I don't know where to touch, so
I think at the bottom you'll see the green share screen.
Oh yeah, okay.
I just made you a co-host so you can share. There you go.
Okay, did you get my?
You did, then yeah, you did. Yeah, we can see it.
Yeah. So I think just to say a few points, I think we need to know how Untitled, or CO2 or capnography works. So capnography works by using infrared light. So and the infrared light, the CO2 has a certain absorption. So if the white area here you see is like say endotracheal tube, and we place that the capnogram right at the tip of the ET tube. So while air is moving in and out, whenever there is a CO2 passing, the CO2 absorbs the infrared light. So on the other side, the capnogram measures how much light come back. So and then realize how much CO2 is there. So that's how it works. So, there are mainstream capnography, like, using in a ventilator circuit. So that's in a closed circuit situation. Or something we do is, we use them like in any airway outlet. So, if we have something, like capnogram, which can measure CO2, and if we, wave it in the air, and, that is connected to a computer tracing, there will be no graph you see, because in the air, the amount of CO2 is almost nothing, is 0.04% or so. So the only way to get, any CO2 read by whatever sensor we have, say this is the sensor, is, you have to get it somehow to air outlet. So which could be our nose, which could be our mouth, or sometimes what happens is the air will be sampled from here and, go somewhere and measured, because the capnogram is somewhere, and it measured it by sampling the air from a distance. So that's what you call side capnogram. Typically that's what you use, for example, in patients on, patient-controlled analgesia, or in, some of the outpatient OR settings. So those are the mainstream and the side stream capnography. But that's where you should get into some kind of air outlets. So the question is, can we depend on it to measure arterial, CO2? Honest answer is you cannot, but it is useful as a trend monitor, because the relationship between the end-tidal CO2 you see here and the arterial PaCO2 is dependent on how much dead space you have in your lung. Like our patients who come with pneumonia, they have a higher dead space. So as the dead space increases, the difference, between the end-tidal CO2 and the arterial PaCO2 widens. So normal patient, for example, like you and me, have about the difference between end-tidal CO2 and the arterial CO2 is about 2 to 5. So this can increase, like in cases like COPD, pneumonia, or ARDS, or it can be lower, like in pregnant patients or like children's. The reason it gets lower in pregnant patients and children's is because the amount of VQ mismatch they have is very low. In pregnancy case, there is a lot of perfusion, so most of the alveoli has a matched VQ mismatch. So so the relationship is dependent on one, our age and things, because as we age, the difference gets wider, and underlying disease and how much dead space we have in the lung. So as you treat these patients, this difference could go narrow, could go apart. So unless you actually measure the PaCO2, it's difficult. But I think the best use of it is the trend. I think anyway, if it goes from where we start, it goes the upward or downward way, I think, we have to look into what the patient is doing to really know what's happening in the PaCO2. It's a difficult question, but I think the best way that you can use is as a trend monitor. And I think if Dr. Tigist is there, I'd like her to comment. I know she told me that they use end-tidal CO2 in the Ethiopian setting, and I don't know how they are interpreting, but as I said, this is like what, in our lung, there are different kinds of alveoli. This one would be better maybe. So this alveoli has, there is no ventilation, there is no air coming here, but there is perfusion. So this is what you call a shunt, so a VQ of 0. So there is no ventilation. So the V is 0. The Q is like, say, normal, so that means it is 0. The second alveoli you see is a well-matched alveoli. So it's ventilated well and it's matched by the circulation. So the VQ is 1. So it's a good alveoli. On this one, on this alveoli, there is no perfusion, but it's ventilated. So this is dead space. So dead space, shunt on this side, and normal alveoli, and there is a range of alveoli between the two. So, that is why, we have to start with a difference in a normal patient, because the alveoli at the, at the back of our lungs or at the dependent portion are, way over perfused. On the other hand, the one on the top are not perfused. So there is a VQ difference across our lung, and that creates a normal difference, and that will be accentuated as we get disease and so on. So, and the CO2 is also dependent not only on the ventilation and how much dead space you have. It depends on your cardiac output. If you see in tidal CO2, somebody has MI and their EF is reduced, it will be significantly reduced, not because of the lung problem, but because of the cardiac problem. The other thing is, which affects is production too. We could be in such hypermetabolic state, like when we are diseased, where we produce a lot of CO2, and that could be the reason why the CO2. So it's a little bit, complicated, but, if you want to use it, it's more, I would suggest more like a trend monitor than the actual PaCO2 measurement. In the US, we have what we call transcutaneous CO2 monitoring, which is CO2 monitoring, which like a SAT monitor, and that probably can relate better with the PaCO2. Even with that, you should always kind of check it first with the blood gas, in order to assess its accuracy. Yeah, so thank you.
Okay, thank you, Dr. Zarian. That was a nice review. So before we end this session, I'd like to remind you guys about what's upcoming. Next week, we're going to start a cardiovascular webinar starting on Monday, May 11. There will be a 6-series webinar Monday, Wednesday, Friday, as we've done the last 2 weeks. So I think it's going to be a 2-week series. The topics will include anything cardiology, including arrhythmias, structural disease. The presenters are cardiologists, again, sponsored by Ethio-American Doctors Group. And we look forward to continuing this relationship. If you have any topics you want to discuss, please forward it to Malaku, and hope to see you guys. And that will complete our mini series. Thank you, Dr. Darun. Thank you, everyone. And
I think,
see you next time.
Malaku, if I say there is one text which came to me from Galau, so I think to send slides. So I think if you don't mind sending that.
Will do.
Okay, thank you.
All right, guys. So thank you. See you next time.